Okay, so it's a more focused talk about using the Abbott system, mitral clip and tri-clip system in the mitral and the tricuspid. So I'll try my best to divide the talk between the mitral and the tricuspid. So same introductory that we had before. MR is bad, fixing it is good. It affects the life, mortality and morbidity, so fix it. Either ways, surgically, percutaneously, medically, just achieve that. So we can see the evolution of mitral clip over the years, as we started in 2003 up to 2019, and now we're going, as I'm hearing, we're going for generation 5, and at the same time, new computers coming in the market with the Pascal system, and which has CE marked in 2019. You can see the generation first, the classical one, and then they got the NT, and we talked much about now NTW, XTW, and NTW, but with the expense of like slight 25 French now going on in the guidance. It was not yet associated with any more vascular complication, but that's to have to keep in mind in case if you need to close that ASD, iatrogenic ASD on the way out. So the task what was given to me to improve the outcome of the patient following TEER. So clinical and structural and procedural factors may play a prognostic role in the repair and should be integrated in the pre-procedural evaluation and in the follow-up. So you have to understand the factors that affect the prognosis of the patient who's going for the procedure and therefore will improve the management in these high-risk patients. We went through this already, and we have some echocardiographic predictors of adverse event that you have to keep in mind. We went through of them, like talking about the flail, restricted leaflet motions, and there is some talk about tethering and angulation, and also dysfunction and dimension and pulmonary hypertension. Keep in mind in COAP trial that they have talked now, when they took a sub-study taking patients who have a PA pressure more than 50 plus or minus above, and people who didn't or have a PA pressure less than 50. Even though that the people who have high PA pressure, they have benefited from mitral clip, yet their mortality rate was higher than those without a pulmonary hypertension. Presence of a TR is bad, and now we have the tri-clip system, which coming in field, so maybe we can eliminate that in the future. So better outcome, fewer complication among higher volume center. We have talked about touch bases in the previous talk. And the better outcome you will get with the fewer complication in high volume. To answer a question was raised before, usually high volume centers we're talking about 50 cases per year. So these are we talked about the transeptal, 50 cases. Even that is not, you're not alone in the center. You have to think about the surgeons. So, and your anesthesia and your echocardiographer. So you have to keep that in consideration and how experienced your surgeons and your team with you. So let's go for a case. So this is a 75-year-old gentleman with multiple medical issue, post-CABG, low AF, and his ejection fraction was dropping despite being in optimal medical therapy. His atrial fibrillation, kidney functions are fine. So the reason is like we consider now clipping because though the symptom wasn't that much because looking at the age in the background is because of the EF has started to drop. So sometimes I once was asking like if a patient is asymptomatic, said like look at your guidelines in the mitral surgical repair. If a patient dropped his ejection fraction, will you fix it or not? We will fix it. The PA pressure is going up. You will fix it? Yes, I will fix it. Then apply to some extent with a grain of salt the rules of surgery to clip to some extent. Ejection fraction, 25%. The RV is good, but we have 2 clefts in the posterior mitral leaflet, and there is coming mainly in the medial jet. We have the annulus, already borderline a bit. We have a septal height, which is like more convincing. We have a good length of a posterior mitral leaflet. And the PA pressure wasn't that bad. Did an angio, everything good. And this is our bicommissural view showing it is more in the medial side. And you can see it here. And this is when you explain it. Those are the 3 pictures that you have to focus in a mitral clip. Bicommissural view, usually at the 60 degrees. And then you can explain it to know exactly. And this is your LVOT, the grasping view. This is more focused because you have to, though it's like he opened the angle a bit, but you can see where is your chords. A 3D will help you in what we call perpendicularity and planning and seeing where is the cleft and the element of calcium maybe, and if there is like a valve or shadowing happening. You can see out of the back it's coming more in the medial side. We took a puncture height. Usually you aim for a mid-fossa posteriorly and a good height, as much as height you can get. And you can see usually this is in the short axis. You go to make sure you're not touching the aorta and your posterior. If you measure the length from here to here, maybe as long as it's more than 2 centimeters, you're in a good shape from terms of the height. What you see here, what is we're checking the trajectory. We explained here on the bicommissural view. It wasn't opening well. That's why in the previous picture, the echocardiographer increased the angulation to open more and show the anterior leaflet. But you can see we're just seeing where is our trajectory going. And after we confirmed our trajectory, we opened the clip, the arms, and we saw the clocking. We were more anterior here, and of course we just, have to go medial lateral and adjust but otherwise we are in like 12 and 6. So we opened the clip arms, and now we're explaining, we're making sure everything is good. We dropped. This is where you can see here in the grasping view that the clip arm is dropping in the anterior mitral leaflet and the posterior, but you see hypermobility is still going on in the anterior mitral leaflet. Posterior, we got it nicely and beautifully. It's well within the apex, but the anterior is still having hypermobility. And why is that is happening? Because we're a bit off axis, and there's still the medial jet going on there. So we're amending our position. So our trajectory is good. It was just a matter of, positioning yourself and adjusting your clocking. You can see out of the back we went more medial here, and he explained again, and you can see the mobility here is a bit still going on, but still the jet is going to happen. So we amended our strategy a bit. We kind of respected the smile. If you consider this is a mitral valve smile here, we went a bit 11:30 to 5:30 to go with the smile of the mitral. Still, there is some jet going on here, but after multiple cutting here and cropping again and adjusting, it is not catched here, but actually the jet was coming from here, so we were amending the position. So this is the second clip coming on. We tried our best to be, we tried our best to be parallel to the first one and as close as possible to the first one. We didn't want to go much medial because if you want commissural, and if you remember the first talk with Dr. Faisal Dalak, there was lots of cords here. You're going to get stuck. So that wasn't the option, or that wasn't the plan. So again, same steps going on. We went this time with a closed arm. And this is, you can see, the anterior is more settled to the apex. A question was raised a while ago about having how much. You have to have a good to the apex and not curling. So now you can see we grasp it. Good MR reduction. Gradient is not bad, so that's another factor. Before you strategize a second clip, make sure that the first gradient is not very horribly bad. Otherwise, you cannot go with a second clip. And you can see out of the back that there's like a very small jet between them, and this was the first one, this is the second one. So we concluded the case as a success, and you can see out of the back that it's a very good result in comparison to the beginning. And here you are, you can see them. The choice was, this is in the NTW, and this was an NT. To consider the gradient, we didn't want to go much with it. And this is the transthoracic the second day. You can see gradient still within intact. We are good. Everyone is happy, and that was the case. So questions been raised again about SLDA. This is about perfecting. You want to be perfect now. You want to have a good outcome, okay? So you have to have fragment. It's the complicity of the lesion, of anatomical factor, or you didn't have enough grasping. We touched bases on that. And asymmetry or incomplete grasping because your clocking or your perpendicularity wasn't the right way, and you were distorting the valve, actually. And putting sometimes XT or XTR may be a factor in injuring, especially in female patients. I showed this case in the beginning of the last case, and this is what I was avoiding in that case. You can see out of the back that I'm stuck here in the posterior and I'm detached from the anterior. The reason for that is because, and the MR is coming from here. This is like an 85-year-old gentleman. We put the one clip in the middle, great MR reduction, but he had multiple jets everywhere. So I was trying my best to go in a more lateral perspective, but because of the multiple cord, we got kind of stuck. Intraprocedurally, I was having wool, good grass. But as we said, a few months later, I think the clip flipped from the anterior and we are just stuck here. And due to the stability and the patient was clinically adjusted medically and not much of symptoms and his age, we didn't see that we should go for another clip. Especially going for another clip, we have to go between two clips and we might knock one of them and have an embolization, and that wasn't, the risk didn't justify the procedure. So I touched bases about SLDA in a tricuspid, which be more maybe because of the learning curve all across the world now. Mitral clip is around since the last 20 years, whereas tricuspid in the last 5 years. This is one of the cases that it's an SLDA. Patient is, by the way, very, very stable, but this is like intra-procedural pictures been taken. You can see it's just attached to the anterior leaflet, 2 clips, where it's like flipped and left the septal. And usually the SLDA happen more with the loss of the septal in the tricuspid. So have a good rotation, make sure about your position, meticulous control when you grasp, and precise, and confirmation. So with that, we'll summary in the mitral. So let's go for the tricuspid, because this is a chapter that me and my imaging team have wrote in this book, which is recently published, The Tricuspid Valve Disease, a comprehensive guide for evaluation and management. And it has very, very good chapters, and I recommend that everyone read it, not because we are part of it, but because of the book is good. So let's go for the screening, because I know most of the people here not have a much familiar, but let's talk about basic anatomy and screening. We focus in few pictures, not much actually. We focus in a transgastric. Unlike the mitral, we look more in the transgastric because it will help you plan your clocking, your perpendicularity, and which leaflet you're going to get. And then you have the RV inflow, outflow, and we explain it, which is your grasping. So you have a mid-esophageal view, you have a transgastric view, and you're going to be good. So this is what we call the RV inflow, outflow, usually in the mid-esophageal. Usually it's ranging between 60 and 90. It depends on your patients. And you can see this is and they explain from here, as you can see. The more you come here, it's like the anterior, and the more you go here in the middle, or you go in the posterior. Once you know your anatomy and you decide where to go, then you go for like the basic bicaval, because your guide is going to come from the inferior vena cava and maybe will be desheated inside of the superior vena cava or in the RA itself. 3D is just a bonus, because as we know that the tricuspid valve is very flimsy, very thin, you're going to see through it. So it's not like the mitral. So if you got it, get it, but if it's not like a mandation. So this is the first one, like the severity of the TR, mid-esophageal, 4-chamber view. You look what's going on. And then you can go, this is another grasping view, which is the 180 or 0. And then you have the grading, and I think this is like being adapted more and more. From mild to torrential, or like massive also, because as the triluminate study is suggesting, even dropping the tricuspid regurgitation by 2 grade, you're still in the severe, like from torrential to severe, patients do very well, and I have seen it. There is now the tri-score system that have been implemented in the last 6 months now, or 1 year, and it works, actually it works. So it's kind of a scoring system. It's not very, popular, but you can give it a try. It looks at the risk factor of the patient in terms of the age, the symptom, the right-sided situation, the kidneys. And I cannot emphasize much on the kidneys, because the worse the kidney situation, the worse volume statics of the patient, the worse outcome you will have. Then you can put it and blot it, and then you can have a tri-score of the patient, which can predict the in-hospital mortality. This was basically designed for surgery, but you can also use it for percutaneous approach. So we talked about the screening. So this is one of my cases I have done in 2021. We go with the mid-esophageal 0 degree. You can see already there is a significant tricuspid regurgitation. This is our RV inflow, what we call. Usually it goes ranging between, as I said, 60 to 90, depends on the patient. And you try to delineate, and this is the 180 or 150 to get the grasping view. So he's trying to get the severity, and this is your transgastric. So this is what we call the interventional view. Finally, we have something in our names, because the surgical view would be upside down. So once you see the liver, it's the posterior, because nothing even behind you except the liver. So this is the posterior, and this is your septal, because you see the mitral here, and this is your anterior. And now you can see there is like something here. Usually the angle is 30 or 35, but you try to go with whatever you can go with it, and you go more flicks and under the heart as much as possible. So he's here arranging And you can, the view, and he made a color compare, and you can see the jet is coming central, which is one of the favorable outcome to have a central jet. Okay, so he explained here what he thought is the problem, and you can see the both leaflet. If you have a multiplanar, it will be better and better. So this is what we talked with. It's important to have a bicaval view, because if you have a Chiari network, if you have a Stakian ridge, it might be interfering with your guide and may have a hold on your guide. Therefore, you have to adjust it and be prepared for the concept. Okay, relative contraindication if there is some clotting in the RA appendage, but it's not much. I don't care much because, again, you're going to have a 350 ACT. So this is our guide here. It's all extended. This is the generation we use. TriClip is still in generation 3, but hopefully within the upcoming few months we'll get generation 4 in the TriClip, and we extend it onto the superior vena cava. So you can see the wire, and I'm just extracting the dilator. Same concept like anything. Take the dilator out, make sure you're on. And you can see there's some Stakian ridge going on there. And this is our clip came out. Because of this, we were afraid of this Stakian ridge can play and impinge on our guidance movement. So this is our clip. We are unsheathing the guide over the clip itself. We used XT here. So now you can see this is your SVC. This is your IVC, and this is where is your tricuspid. So your trajectory should be go like this. But this is the bicaval or modified bicaval. Out of the back, you can see I'm pushing on the septal. So that's what we call a septal hugger. And that was the problem with the old system, the off-label use of mitral clip, that you're always, septal hugger, and you might cause problem with that. So they have amended. You can see the curve on this. Okay, so this is the RV inflow. They explain it because this is going to be my trajectory and my grasping view. I'm bended here a bit because I'm toward the septum. So we amended the guide. You can see out of the back that the change in the curvature of the guide and the clip here itself. But my direction isn't that great yet. My trajectory isn't great, so I have to amend it. So now look at this. So direction now is like if you took a ruler here and put like a straight line, you can see you're more at a 90 degrees going on, and that's what your target. We talked about your screening. You're in the middle. So this is your septal, this is your posterior. And usually they say lateral because it's going to be confusing. You're saying posterior, anterior. So just to make it simple, even in the guide, you will find septal and lateral, S and L. So this is here he exactly explained on this, and this is where am I exactly, with the perfect trajectory going centrally. We're adjusting ourselves. We can see, when we're trying to test it on real life, we found ourselves going more directly to the septum because from the beginning we were septal hugger. So we amended this a bit. You can see the trajectory have changed a bit, and we opened the clips of the arm. Again, in the grasping view, you will see both arm. And as if this, you can imagine this is a bicommissural view, you will use just one side of it, just to give you a hint if you are not perpendicular. So usually what we do, we go for the transgastric. I try my best not to push the clip inside of the, through the leaflet, and I just ask that, you see, he can change his degrees to come and see me, rather than the other way, I go down for him to see me. And this was my technique. Our technique or strategy was the clover technique. We have, this is your septal, and this is your anterior. We just go from 2 to 8 and grasp both of them. And then the second one will be here. You can argue, why didn't you start from up downward? Because once you put something here, it's going to cast a shadow, and then you're not going to see. So that's why we start from anterior to posterior. So here you can see we have a good septal entry to some extent, just need improvement, but I cannot see the tip of the lateral. So we're adjusting it more. We have a better inside of the septal, but still the anterior is hard to tell about it. Now you can see the tip of the lateral one is in the apex, whereas this one is kind of rolling. This is a recipe for detachment, so you have to be careful about it. And as we do the first grasp, still, usually, because, usually in tricuspid cases, percutaneously, you will find them female, you will find them having atrial fibrillation, and they will be old, and they will have a lung problem in the background. So you have to be very careful, opening and closing, and XT especially, because it will not work with using an NT. So be careful, because you don't want to damage the leaflet. So we weren't like 100% closed in this situation. Now we close 100%. You can see the leaflet is well in and well tethered. And you can see in the transgastric, well approximation. And this is what you can see here is the anterior papillary muscle, like you're defining anatomical mark if you want to know where is your anterior, where is your posterior. And you can see this is the only jet. So we delineated or eliminated completely the anteroseptal jet, and we are left now with the posterior jet. Make sure of the gradient before you deliver and you are in trouble. Yes, gradient is great because, again, this is not the mitral. It will not tolerate more than 3 or 4. Like the aim is 3, 4. Don't go beyond that. And that's what we call a Clover technique. First one was like this, second 2 to 8, and then second one will be 3 to 9. This is your septal, this is your anterior. You can see this is the leaflet. You have to accustom. Unfortunately, tricuspid is not a good imaging situation, so you have to accustom to grasp sometimes the transgastric pictures, and you can see the leaflet just going inside. And this is when after we grasp it, you can see the pulling of the lateral our anterior leaflet, and the septal wasn't much here shown. But you can see we have eliminated the posterior jet. Excellent results. Gradient is good. And this is our post-procedural. So next day, fine. We have some squirt of a TR. It's fine. We didn't have gradient is good. Patient is good. And you can see out of the back, the IVC was completely collapsed now. Now, regarding the volumetric evaluation of the patient, it is advised for tricuspid cases to diurese the patient a bit to approximate the leaflet, but not on expense over diuresing them and having a problem. That's why I said in the beginning, renal failure patient or dependent on dialysis might be hard to control this situation. And the next day, don't stop the diuresis yet. Give them a couple of days for the RV to accommodate the new volumetric situation. And then you can downgrade your diuretics. With that, I will thank everyone. Thank you.